The wrist joint, I recommend dividing the wrist joint into the palmar, dorsal, radial, and ulnar aspect. Palmar aspect. The palmar region, the median nerve, carpal tunnel, Guyon's canal, and scaphoid bone are inferent structure. The space between the transverse carpal ligament and the carpal bone is the carpal tunnel, and the space between the transverse carpal ligament and the palmar carpal ligament is the ulnar canal and Guyon's canal. Centered around the interosseous membrane of the distal forearm, the anterior interosseous nerve is in the palmar part, and the posterior interosseous nerve is the dorsal part. Carpal tunnel. The boundary of the carpal tunnel are as follows. The proximal and distal part of the radial side contain the scaphoid and the trapezium. The proximal and the distal part of the ulnar side contain the pisiform and the hook of a hamate. The superficial part contains the transverse carpal ligament, and the deep part is carpal bones. When examining structure within the carpal tunnel, it is recommended to first observe them transversely and then longitudinally. In the case of a transverse view, the examination is performed from proximal to distal with the forearm spinated. That is the area from the anterior of the distal radius and the distal part of the carpal tunnel is examined. In the longitudinal view, abnormality in the median nerve located deep, radially to the palmaris longus tendon should be examined. It is recommended to examine the posture of the wrist joint in the neutral position and then slightly flexed rather than extended. The reason is that when an ultrasound examination of the carpal tunnel is performed with the wrist joint extended, the flexed tendon is observed in the hypoechoic due to anisotropy, due to the ultrasound insonation angle. In this case of the flexed distal superficialis tendon, and the median nerve can be distinguished by actively flexing and extending the fingers. This is because the flexed tendon glides according to the movement of the phalangeal joint, but the median nerve does not move. Ultrasound findings that indicate carpal tunnel syndrome are as follows. In the case of a transverse examination, first, the cross-section area in the median nerve is generally observed to be wider than the 10.1 square millimeter at the proximal part of the transverse carpal ligament. However, since the normal reference value may vary between individual or between men and women, it is recommended to compare the cross-section area of the median nerve on the healthy side and the affected side. It is considered significant if the cross-sectional area of the median nerve differs by more than 2 square millimeters when comparing the healthy side and the affected side. Second, due to the sternizing tenosynovitis in the carpal tunnel, the boundary of the flexed tendons are clearly observed in the hypoechoic. When observed in the longitudinal view, when the transverse carpal ligament thickens and compresses the median nerve proximal to the compression is observed thickened. This is called the notch sign. In some cases, thickening of the median nerve may be observed distal to the area where the median nerve is compressed. In these cases, it is called an inverted notch sign. Among the many ultrasound findings observed in the carpal tunnel syndromes, the most important is the increase in the transverse cross-section area of the median nerve, measured more proximally than the transverse carpal ligament. Tenosynovitis and the tendinopathy. Due to the excessive use of wrist joint, tenosynovitis or tendinopathy commonly occur in the flexor carpi radialis tendon and the flexor carpi alaris tendon. Tenosynovitis occurs because the wrist flex tendon is surrounded by the synovial membrane. However, the flexor carpi alaris and the palmaris longus tendon are not covered by synovial membrane. Therefore, the flexor carpi alaris and the palmaris longus tendon are tendinopathy and not tenosynovitis. Calcific tendinitis often occur in the flexor carpi lattice tendon, so careful observation is required. When performing the injection therapy of the tenosynovitis, there is a high possibility of the tendon rupture if intratendinous injection performed. So be careful to use ultrasound to ensure that the needle is injected peritendinosus injection without piercing the tendon parenchyma. Guyon's canal syndrome. Ulnar canal syndrome is a syndrome is entrapment of the ulnar nerve within the ulnar canal, and space-occupying lesion is known to be the most common cause. In addition to the space-occupying lesion, sometimes the ulnar nerve is compressed between the abnormal muscle, the accessory abductor distae minimi, and the abductor distae minimi muscle. Scaphoid bone. The scaphoid bone is bent at 30 degrees relative to the wrist joint when viewed from the lateral side. If the wrist joint is hypoextended 30 degrees, then the deviation occurs. The scaphoid bone is aligned most parallel to the anterior of the wrist joint. If the probe is placed between the scaphoid bone and the radius scaphoid joint and scaphoid bone can be clearly observed. Scaphoid fracture that difficult to observe on plain radiography can be relatively easily detected with ultrasound. The scaphoid Palmar approach is the method of observing the continuity of the cortical bone and the formation of the hematoma by placing the probe between the scaphoid bone and the radius. The radial approach of the scaphoid bone measure the distance between the radial artery and the radial border of the scaphoid bone. If the distance between the affected side and the healthy side increases, the scaphoid fracture should be suspected even if cortical bone breakage is not observed in ultrasound.